Thank you very much, Alana and Claire, and I appreciate the opportunity today to give you a national perspective on one of our highest priorities in the division of STDs, which is the concern of burden of STIs among adolescents in the United States. So in the time that I have, I'm just going to review quickly the important highlights of the STD burden among adolescents. I'm going to review why adolescents are at increased risk for sexually transmitted diseases or infections compared to older populations. I will review the STD clinical preventive services for adolescents that are recommended, and certainly we're interested in finding ways to scale up these recommendations so that we can improve health outcomes. And the areas that I'll be discussing are chlamydia screening, HIV screening, and HPV vaccination. A few suggestions on how we might be able to close some of the gaps where we're not utilizing the effective interventions that we have available to us, and leave you with some resources that might be of benefit to you. So starting with the STI burden among adolescents, as it was mentioned, when we actually look at the sexually experienced population in the United States, individuals aged 15 to 24 years of age account for only 25% of the sexually experienced population, yet they represent almost half of the new STIs that we see in this country. So clearly a disproportionate burden of infections among our younger population that have the most to lose in terms of lifelong health consequences if these infections are not taken care of or prevented. This is a new study that was recently released by CDC looking at what we estimate to be the number of sexually transmitted infections in the United States, with the purple bars being the age group 15 to 24 and the bluish-green bar of over 25. So if we start with HPV on the right, you can see that we estimate there's probably over 14 million new cases of HPV in the United States annually, and at least youth represent 50% of those cases. Chlamydia, on the other hand, which is our second most common sexually transmitted infection, but the most common reportable infection to us at CDC through our surveillance systems, with over 2.8 million cases annually. But here you can see 63% of the cases occur among young people. Not as many cases among trichomoniasis among young people, only 13%. Again, gonorrhea disproportionately affected by young people with our 820,000 cases. And we're also very concerned about gonorrhea and the threat of untreatable gonorrhea, with us having only one drug left to treat gonorrhea. And 70% of those cases occur among 15 to 24-year age groups. The highlight I'd like to point on the left side of the graph is, if you notice, among hepatitis B in this country, we estimate there's only 19,000 cases. And if you look at the age group between 15 to 24, there's less than 2,000 cases annually. And this reflects the successful hepatitis B vaccination program we've had through perinatal programs and through school-based vaccination. So this has been quite a public health success, and I'm hoping we can take home some messages from our hepatitis B successes that we can apply to HPV and any other vaccines that may come along for sexually transmitted infections. Again, this is looking more closely at prevalent infection. These are the number of cases that exist in a population at any given time. This is different than incident infection, the new cases. These data come from our NHANES, the National Health and Nutrition Examination Survey, where it's a nationally representative sample, so it gives us very precise information about prevalence of various conditions in the United States. And as you can see, overall nationally, in the 14 to 19-year age group, the overall prevalence is 6.8% when we had most recently measured it. And we're also very concerned about the health equity issues and the health disparities we see among our STIs, with African Americans or non-Hispanic blacks having significantly higher prevalence of all our STDs. And for chlamydia among adolescents, the prevalence nationally is 16.2%. We also are monitoring where we see our cases through our surveillance case-based reporting system. I think in years past, traditionally, most individuals and young people at risk for STIs were seen either in STD clinics or family planning clinics. And basically, what we're seeing now is more and more of these patients are being seen in the private sector. where almost 40% of women with chlamydia in 2011 were reported from a private physician or a health maintenance organization. And only about 12% were seen in family planning clinics. In terms of our HPV prevalence, we've also been monitoring HPV prevalence in U.S. women between the ages of 14 and 59 through the NHANES survey as well. And you can see that the peak prevalence occurs in our 20 to 24-year-old age group and then slowly declines with age. But there's a significant prevalence in the 14 to 19-year-old age group, averaging at least for the high-risk HPV types that cause cancer, at about a prevalence of 25%. I also would like to mention HIV because we have some new HIV screening recommendations that came out through the U.S. Preventive Services Task Force in April of this year. A lot of people don't recognize that 1 in 4 new HIV infections occur in youth ages 13 to 24 years of age. And that we estimate about 12,000 youth in 2010, which is about 1,000 new infections a month, occurred among these younger people with HIV. So this is something that we are encouraging providers to be aware of the number of new HIV infections that we're seeing in this country among youth. A number of these infections are among men who have sex with men. And as you can see again on this graph, we see the same health disparities with, when we looked at in the year 2010, of the new cases of HIV in people aged 13 to 24, 5,600 were among Black or African American males. So in summary, in terms of the impact and burden of STIs in this country, we've got a lot of infections. We're mainly concerned about the reproductive health and impaired infertility that we see with chlamydia and gonorrhea. We're concerned about the adverse pregnancy outcomes that are most significant with untreated syphilis and herpes. Clearly, we know that HPV causes reproductive tract cancer, and we generally believe that most of our STDs, both bacterial and viral, facilitate HIV transmission. So overall, among young people aged 15 to 24, we estimate there's about 9.8 million annual new cases of sexually transmitted infections with a cost of $6.5 billion annual direct costs in this country a year. So clearly, a high burden, high cost concerning public health problem. Now, just to let people know a little bit about chlamydia, in case you're not aware of sort of, what the risk and what are the consequences of chlamydia. Most of the significant health outcomes relate to the sequelae that we see in the female. We estimate that about 10 to 15% of untreated chlamydial infections will go on to clinical PID. We also recognize that a number of untreated chlamydial infections, because most of these infections are asymptomatic, people do not know they're infected, go on to a subclinical tubal inflammation that goes on to tubal factor infertility. We don't have the science to actually quantify this risk as well as we do when we know about clinical PID, but about 10 to 15% of young women or women with clinical PID go on to tubal factor infertility, and we do know that chlamydia is the most common, preventable cause of tubal factor infertility in women. And then in terms of the natural history of HPV, we know that HPV, especially the high-risk types, will infect the cervix, but it's only the persistent infection that causes the precancerous lesions and goes on to cancer. Most people that are infected with HPV, including the high-risk types, clear their infection and have no long-term consequences. We know that HPV is necessary but not sufficient for cervical cancer, and we're currently seeing the peak incidence of precancers in the late 20s, and those who have cervical cancer starting in the late 30s or 40s. So next topic to discuss is, why are adolescents at such high risk for these infections? And there actually are about 5 important factors as to why we see a disproportionate number of youth at risk for STIs. Certainly we know that all of our infections are asymptomatic. So one, young women and adolescents don't know they're infected, so they don't know to come in and get checked. We also know that many of them do come in for healthcare services, but providers are unaware that they need to be checking and screening for these infections. So one of the big factors is that we have insufficient screening for these infections, especially for chlamydia. We also know youth have concerns about confidentiality, and they're reluctant to disclose risk behaviors to doctors. They're reluctant to come in for these type of concerning problems. And actually in young adolescent women, there's even biological factors that are very different from a more advanced older woman in terms of the target cells for chlamydia known as squamous epithelium is more exposed at the cervix in the young adolescent as they're going through puberty. There's also changes in the mucus plug and other things so that makes them more susceptible to these infections. We also know youth often lack health insurance or transportation and really do not access health care as frequently as they need compared to some other older populations. And then certainly there are the sexual behavioral factors of many young people have multiple partners, which is an important risk factor for sexually transmitted infections. Moving on to sort of the clinical preventive services that we expect adolescents to receive in this country based on the evidence that these are effective interventions. We know that there's a lot of issues in achieving high rates of success in these prevention interventions. Some of these are provider knowledge and attitude issues. We know for chlamydia that often there are low screening rates because providers do not have information about the disease rates in their community. Some providers believe their patients are not at risk, and therefore they may do a physical exam, not see anything, and decide not to test. Some do not feel that they can offer confidential services to adolescents. Some believe that STDs are not urgent medical conditions. They're easily treated. They're not high on the priority list. And obviously, the amount of time that providers have to take care of many problems of their patients usually can be spent dealing with acute medical problems, and the preventive services often are not attended to. We also know there's some more systems issues around insurance coverage and adequate reimbursement. Some clients are challenged by high copays and deductibles, and then we are also challenged by how to maintain confidentiality with billing and explanation of benefits. So these are some of the things that we've identified as barriers to scaling up our known effective screening interventions. I do want to let people know that it's important to know what your state laws are. I'm just highlighting the confidentiality laws, but all 50 states and the District of Columbia allows minors to consent for STI services. There are some nuances in certain states about the age the minor can be. Some states include HIV in the STI services. Some include vaccination for HPV, some don't. So I'm not going to go into the details because these laws vary by state, but the important thing to know is that all states at least allow minors to consent for STI services. Obviously, there are exceptions when there's suspected physical, sexual, or emotional abuse, or that the patient may be harmful to themselves or others. And it's also important to remember that despite these confidentiality laws, providers are still in all states required to confidentially report at least chlamydia, gonorrhea, and infectious syphilis to their local health department. CDC follows recommendations from the U.S. Preventive Services Task Force, and since about 2000, chlamydia screening for females less than 25 years of age annually has been recommended, and screening of women over the age of 25 or 25 and older should only be done if there is increased risk. So we clearly have clear recommendations that young women need annual screening. Young women that are sexually active need annual screening for chlamydia. Chlamydia is easy to diagnose and it's easy to treat. We now have nucleic acid amplification tests that are very sensitive and very specific for diagnosing chlamydia. These tests can be done on urine samples, vaginal samples, cervical specimens, urethral specimens. We also have labs in the United States that have done validation studies and can also collect specimens in the rectum and in the pharynx. So again, you need to ask your lab what type of services they have available to you in terms of their NAT testing. But we've recently learned that actually for the female, the best specimen to collect is actually a self-collected vaginal swab. Now again, unfortunately, the test is only approved for the self-collection to be done in a clinical setting, but some labs have also started to do validation for home collection of vaginal swabs for chlamydia, which certainly is very helpful when you have a case of chlamydia and need to rescreen at 3 months. If you can avoid the office visit and get the swab to your patient at home, it saves a lot of resources and time for everyone if women can start doing more home collection. I think this is going to be something we're going to be looking at in more detail in the future. And again, treatment is simple and efficacious with either a single dose of azithromycin or oral doxycycline, 100 milligrams twice a day for 7 days. So we clearly know what we should be doing, but we're not making great progress in improving our chlamydia screening coverage. These are trends from screening rates based on HEDIS measurement criteria in our Medicaid programs. If you look at the dotted line, that looks at the percent of young women in Medicaid, the 16 to 20 who are being screened for chlamydia. We're almost up to maybe 50% coverage. We would really feel that we need to be up much higher than that. And certainly in managed care plans, we're lagging behind with approximately about 30% of young people being screened for chlamydia. A lot of people have questions about, we're focusing all of our screening on women. What about men? Well, first of all, for men, there's really no serious outcome of chlamydia infection in a male. The adverse outcomes are mainly in the female reproductive tract. We know that men are hard to reach, have less health insurance coverage, but our current analysis that we've done at CDC does not recommend broad-based male screening. We think the male partners of chlamydia-infected females are the men that you should be targeting. I don't have time to go into how we are trying to make sure that all partners of infected individuals, especially of women, are treated. We have 2 randomized controlled trials that show that expedited partner therapy, which means providing medication to your patient with chlamydia or giving them a prescription to take home to their partner who's unlikely to seek care in a timely fashion. It's a harm reduction model. Ideally, you'd like to get the partner in for care. But if that's not possible, then expedited partner therapy is an option to get the partner treated without doing a good faith medical exam. And this has been endorsed by CDC and many medical associations. And again, it's something that's dependent on state laws, but most states in the United States now have exemptions to either their medical care acts or their pharmacy boards that do allow providers to provide extra medication to a patient if it's unlikely the partner is going to come in for care in a timely fashion. In terms of HPV vaccine recommendations, it is now recommended for routine vaccination of females aged 11 to 12 years with 3 doses of either the bivalent or quadrivalent HPV vaccine. Also, for those 13 through 26 years of age who have not been vaccinated previously or haven't completed the 3-dose series, you can continue vaccinating up to the age of 26. And more recently, routine vaccination of males was recommended by ACIP for males aged 11 to 12. With 3 doses of the quadrivalent vaccine, because that includes also the types that cause genital warts. And also the recommendation only goes up to the age of 21 years for those males who haven't been vaccinated previously or haven't completed their 3-dose series. However, for gay and bisexual men and other men who have sex with men who are at higher risk for anal cancer, the age range is recommended to go up through age 26. Again, we are making slow progress in this country around HPV vaccination coverage. These are data from the immunization survey of teens from 2006 when the vaccine was introduced for girls to 2011. And as you can see, providers are doing a good job of improving on the new recommendations around Tdap and meningococcal vaccine. Above 50% of adolescents are receiving these vaccinations, but less than 50% are receiving 1 dose of HPV in girls, and significantly less of these girls, barely 25% of young girls in our country are receiving 3 doses of the HPV vaccine. There's been a number of studies on sort of barriers to vaccination. We know we have some concerns about vaccine hesitancy among some partners, but we also have learned that providers are not strongly recommending the HPV vaccine in comparison to the Tdap and the meningococcal vaccine. It's often presented as an optional vaccination. If a parent expresses sort of, mixed or negative opinions, concerns, the provider becomes more reluctant about making a strong recommendation. They don't want to engage in this discussion. And some providers in these studies that were recently published in 2011 also share parents' views that teens are not at risk for HPV and therefore vaccination can be delayed until maybe they're closer to onset of sexual activity. In terms of the HIV screening recommendations, this is our third area that we need to package for comprehensive adolescent preventive services. Again, in April of this year, the U.S. Preventive Services Task Force recommended that clinicians screen for HIV infection in adolescents and adults from 15 to 65 years of age. This is an A-rated recommendation, preventive services. Clearly, younger adolescents or older adults who are at risk are also recommended to be screened. But the evidence was insufficient to determine the optimal timing interval for screening. So there was a general recommendation that you should consider repeat screening if someone is at risk, continued risk for HIV infection, that they're having high-risk behaviors, or they're living in a community with high prevalence. And CDC's defined a high prevalence geographic area or community of one with a prevalence of greater than 1%. They also mentioned settings where there could be higher risk, and adolescent health clinics are one of those settings where if you have a high prevalence of STDs, you should be screening your adolescents more frequently for HIV. In terms of closing our gaps, we do recognize that providers have a lot on their plate these days, but we really need to be doing better training so that more providers, especially in the primary care world, are aware of these infections, their consequences, their costs, and are offering the appropriate preventive services to their clients. We want to be developing more tools and identify systems issues that can facilitate office-based screening and vaccination, and keeping everyone up to date on how to promote quality measures to improve the care of adolescents. We also know with the changing healthcare environment, we do have some opportunities in the next few years where we're hoping that there will be an increased proportion of people with health insurance coverage, especially younger populations, especially younger men. We also recognize that our healthcare system is interested in quality, so we want to find ways that we can scale up these preventive services. And we also know there's a whole new investment in health information technology, and are hoping that we will be able to allow the technology to help us with clinical decision support, e-measures, and things like that. So I'm going to end because I'm running out of time, but I would like to let everyone know at CDC we do a lot of provider work around our STD treatment guidelines. These are our authoritative evidence-based source for STD clinical management. They're available on our website. We've got wall charts and pocket guides and ebooks. We do webinars, podcasts, and we also now have an STD mobile app that just came out last month for Apple devices and Droids. It is based on the 2010 treatment guideline. We're in the process of revising that and expect to have our 2014 STD treatment guideline out next April. CDC also has a lot of websites related to a network of training centers we have, and I know our next speaker comes from one of our training centers. So there's a lot of offerings through the National Network of STD HIV Prevention Training Centers. We have fact sheets for providers and for patients, and there's also a lot of information around vaccine safety and HPV vaccines for teens and for providers. So in summary, we believe that we have an urgent public health priority with our STDs in adolescents, and it's everyone's responsibility. Our effective prevention interventions are underutilized, and we need to try a more holistic and combined prevention intervention approach at all levels, including parents, adolescents, schools, communities, healthcare providers, healthcare plans. We need to maximize prevention through our healthcare opportunities and continue to build best practices and models to make this easy for everyone. So with that, I'd like to thank you